Hello, friends. So, I'll be very briefly talking on this very broad topic, management of life-threatening electrolytes and metabolic disturbance. So, this was part of a FCCS course, Fundamentals of Critical Care Support course, which was organized by my two good friends, Dr. Jaiprakash and Dr. Seeman Jha in Ranchi Institute of Medical Sciences. So, I wish to acknowledge FCCS of Society of Critical Care Medicine. The content will be from FCCS. So I'll be just taking you through a case scenario and touching about the basic aspects of major life-threatening electrolyte disturbances. So I wish to acknowledge FCCS for the source of the content for this presentation. So the objectives of this particular topic, management of life-threatening metabolic disturbances, is to review the emergent management of severe electrolyte disturbances and specifically look on steroid cortisol insufficiency or adrenal insufficiency, the way it manifests and the treatment principles. And very briefly, we'll look into management of severe hyperglycemic syndrome. So we'll take you through certain case scenarios and the evolving electrolyte disturbances and management of it. So we look into case study one. It's a 65-year-old gentleman who presents with confusion and with a premature ventricular contraction. So he has ectopics and he has diarrhea. And this is in a very hot, arid climate without an air conditioning. So our understanding is, so in a hot weather without air conditioning, someone having diarrhea and manifesting with confusion with the PVC. So it portends very concerning sort of a situation. And diarrhea would obviously lead to a lot of depletion of water and electrolytes. So that is the sort of a context setting. So when you look at the vitals of this gentleman, heart rate was 116. So slightly tachycardic, blood pressure little on a borderline, saturating well and maintaining good respiratory rate. So the question one would ask is, so what are the risk factors and electrolyte disorders that could be present in this individual, which is leading to his confusion? So obviously the things that come into your mind is he could have hyponatremia, he could have hypernatremia because of a lot of water losses, or there could be severe potassium deficiencies, which can lead to cardiac disturbances or magnesium deficiencies, so on and so forth. So when it comes to principles of electrolyte, so you do not look and search for what is the etiology of electrolyte disturbances. You rather look at electrolyte disturbance and start treating it. So treating and etiology goes hand in hand, and they have to happen concurrently. You don't say, let me try to ascertain what is the cause of hypokalemia and then I will treat. So both have to happen concurrently. And the quintessence of management is based on clinical symptoms, and it is not specific to what is the electrolyte number. Suppose if patient has cardiac disturbance, even with a potassium of 3.4, so our course correction has to be a little more aggressive as opposed to someone very stable, young individual, 3.4, you can take your time and correct it. So the clinical context determines the intensity of management of electrolyte deficiency. And the treating urgency is not determined only by the level, but on the clinical profile of the patient and the clinical setting of the patient. Most importantly, once you treat, one needs to keep reassessing the electrolyte levels and make sure that they have normalized. Because if someone has a potassium of 2.5, you start correction, it is imperative and expected out of you to repeat the potassium and whatever disturbances to see if it is normalizing, and don't sit quietly on it. So those are some of the broad principles that govern. So with regards to this case, who presented with confusion and who had a PVCs and diarrhea, his potassium comes as 2.3. So now one has to ascertain what are the possible causes of hypokalemia. So hyperventilation is something that can lead to hypokalemia, and this patient had diarrhea. So any fluid losses, diarrhea, vomiting leads to hypokalemia, or someone who is on a nasogastric drainage. So there's a lot of gastric losses that can lead to hypokalemia. Malnutrition can cause hypokalemia, and severe nutritional deficiency, anorexia, alcoholism can lead to hypokalemia. And most importantly, for all our trainees, understand that hypomagnesemia occurs concurrently with hypokalemia. So if there is hypokalemia and you do not correct magnesium, invariably correcting that low potassium becomes refractory, because both have to be corrected simultaneously, because it forms a vicious conundrum that hypokalemia leading to hypomagnesemia or hypomagnesemia leading to refractoriness of correction of hypokalemia. And if someone is taking insulin, or if the patient is being treated for DKA or high sugars, that will push potassium into the cells, so potassium can be low. Or someone, you are a bronchial asthma patient or COPD, you are giving continuous beta agonists, so that also can lead to hypokalemia. And there can be renal losses of potassium, which can lead to hypokalemia, because some of the renal tubular acidosis, they can lead to potassium loss, so on and so forth. So renal losses also can lead to hypokalemia, or diuretics, where there is a lot of water loss. I think some of them can lead to low potassium. So when you do a ECG for hypokalemia, the typical features in severe, if it's a potassium of 2.3, you would see a U wave, which is after the T waves, and the T wave becomes very shallow. So the T wave is small, and there is a big U wave that comes, and there can be diffuse STT depression. So this is a typical features in ECG you would see in severe hypokalemia. So because it's an opposite. In hypokalemia, T waves become shallow. In hyperkalemia, T waves become very tall. And U wave is an additional wave that comes in hypokalemia. Okay, so these are some of the features. So what is the treatment of hypokalemia? So when it comes to treatment of hypokalemia, whenever potassium is less than 3.5, it mandates that it has to be treated. So you divide into two broad categories. Whether potassium is very less than 2.5. If your patient is on digoxin, you take 3 as severe hypokalemia, because the digoxin toxicity is accentuated by hypokalemia, and you have to be a little more aggressive in correcting hypokalemia. So if it is a life-threatening symptoms, like you see in this patient, potassium of 2.3 with a PVCs, one has to correct potassium intravenously, and the dose you would give is 20 to 30 millimoles per hour, can be given slowly as an infusion until the potassium is corrected. If it is non-life-threatening and there are no symptoms, so one could think of giving oral supplementation of KCl 20 to 40 millimoles every 2 to 4 hours, or you could give KCl at 10 millimoles per hour as an infusion. If potassium is less than 3.5 and more than 2.5, no symptoms, you can resort to using oral supplementation with potassium syrup, KCl 20 to 40 millimoles, 4 to 6 hourly. So this is just a very simple algorithms trying to say either you can give IV. IV you would give if they are symptomatic. In ICU, for all our listeners, invariably they are considered critical, and the potassium supplementation is almost always IV formulation. So you can give 20 to 40 millimoles every 4 hours, say, as a slow infusion, or every 6 hourly, so on. But you have to keep repeating potassium to ensure that it has normalized. Frequent monitoring is important. So coming back to case study, patient has received KCl in the emergency. This patient, who came with diarrhea, confusion, and PVCs, who's had a potassium of 2.3, had received potassium in ER. You do a repeat potassium, it comes 7.8. So obviously, the underlying clinical condition has led to hyperkalemia. So patient developed stall T waves. As I said, in hypokalemia, it's a shallow T waves and a U wave. Here you see a broad complex QRS and with a tall T waves, and then they can go into sine wave pattern and they can have a cardiac arrest. So then you have to determine what are the causes of hyperkalemia. So hyperkalemia can happen due to hypoaldosteronism. So, or due to acute kidney injury. It's very intuitive for every listener to know any chronic kidney disease or acute kidney injury leads to hyperkalemia. When there is hypoaldosteronism, it can worsen the hyperkalemia. Acidosis. So this patient had diarrhea, and possibly this patient had pre-existing acidosis. Acidosis can perpetuate worsening of potassium levels and hyperkalemia. Or if this patient may have been on AC inhibitors or spironolactone or aldosterone antagonists or NSAIDs, all these can worsen hyperkalemia. Or there can be tissue. Patient can be severely dehydrated following whatever exhaustion. They can have rhabdomyolysis or hemolysis or tumor lysis if they have. So all any cell breakdown can lead to hyperkalemia. So now the question is, how would you treat hyperkalemia? So we treated hyperkalemia. Now you repeat the labs, and this can be spurious level also. Some you may have during blood aspiration, the blood may have hemolyzed. So sometimes if you think it is spurious, you may have to recheck the potassium. But if it is a true hyperkalemia, you have to obviously treat the hyperkalemia. How would you treat hyperkalemia? So there are three components of treating hyper. One is cardiac stabilization. Obviously, first priority is to protect the heart and preventing it from going into cardiac arrest. We have to give calcium. This is cardiac. And the second step is redistribution of potassium. And the third step is removing the potassium. These are the three components. So the first step is to protect the heart by giving calcium. So 10 ml, 10% calcium gluconate has to be administered slowly, IV, maybe over 5 to 10 minutes. And the second main dimension of correcting hyperkalemia is to create a redistribution of potassium by giving dextrose and insulin infusion. You can put 10 units insulin in 25% or 50% or 50 ml dextrose and give it over 2 to 4 hours. And sodium bicarbonate can be given to redistribute potassium. And beta agonist nebulization. We saw beta agonist nebulization can lead to hypokalemia. So you can give salbutamol as a nebulization, continuous nebulization. These are the steps to redistribute potassium. And there are steps to remove the potassium. And what are the modalities that are available? You can use diuretics. If patient is passing urine, you can use diuretics to remove potassium. And typically what we use is K-bind, which is calcium polystyrol sulfonate powder. This binds to the potassium, helps in elimination of potassium. If all these steps are ineffective, then obviously we have to put the patient on dialysis to reduce the potassium. So these are the three broad dimensions of treating hyperkalemia. So coming back to case study, 65-year-old man with diarrhea, excessive sweating, come with confusion and lethargy, has a PVC, then you do a sodium. Sodium comes as 108. So he has hyponatremia now. So the whole concept of hyponatremia and your understanding of sodium is little broad. It has to be broad-based. It's not as simple as potassium. So maybe I'll take little more time in explaining about this hyponatremia. So how would you determine the etiology of hyponatremia? So I'm sure for all the trainees listening, hyponatremia is a big subject and you need to have absolute clarity how you approach a case of hyponatremia. Any sodium less than 135 millimole per liter in the absence of hyperglycemia, it is almost always having a low osmolar state. You call it as hyponatremia. So in hyponatremia, our understanding is your intracellular fluid compartment is more. There is more intracellular fluid, but the extracellular fluid can either be low, can either be normal, or can be high. This is in a hypoosmolar state. So for this, you need to understand there are three steps in kidney to excrete water load. So the way kidney excretes water is by secretion of water and electrolytes into the distal convoluted tubule. And there is reabsorption of sodium and chloride from the loop of Henle. And there is maintenance of dilute urine in the collecting tubules. These are the three steps how kidney gets to diuresis and gets the water out. So it maintains. So in the absence of antidiuretic hormone, kidney, there is maintenance of dilute urine in the collecting tubules, which gets excreted. So these are the three steps which help kidney to excrete water load. So when you talk about hyponatremia, we divide it into three broad categories. Hyponatremia most often occurs in hypoosmolar state. There are very few causes where hyponatremia occurs in normal osmolar, which we call it as pseudohyponatremia. And there are only two conditions where hyponatremia is caused due to hyperosmolar state. Normal osmolar state, there are only two conditions, hyperlipidemia, paraproteinemia, which we call it as pseudohyponatremia. With high osmolarity, it happens only with two conditions, hyperglycemia and administration of mannitol. All other causes of hyponatremia are associated with hypoosmolar state. So that is something you all have to be absolute clarity. Normoosmolar, hyperlipidemia, paraproteinemia. Hyperosmolar, hyperglycemia, and administration of mannitol. All other causes of hyponatremia are due to hypoosmolar state. And in hypoosmolar state, the intracellular fluid content or the water content is high, but the extracellular fluid can be either low, can be normal, or can be high. So this is how you approach hyponatremia. And there is sodium loss with water gain and hyponatremia with reduced extracellular, which means extracellular fluid is less. What are the conditions where patient has lost the fluid? It can be due to vomiting, it can be due to diarrhea, it can be due to diuretics. These are the only, or due to increased sweating. These are the only conditions where hypoosmolar hyponatremia occurs with reduced extracellular fluid. So there is in all the pathognomonic feature or the pathophysiology of hyponatremia, In hypoosmolar hyponatremia due to normal osmolality, low osmolality, or high osmolality, the cause, the pathognomonic pathophysiology is only increase in the vasopressin levels. The relative volume deficiency is there, and there is increased production of vasopressin. So the pathophysiological underpinning of all hyponatremia is increased antidiuretic hormone or vasopressin levels in the body. So vomiting leads to reduced extracellular fluid, diuretics leads to reduced extracellular fluid, or any interventions which pushes the potassium out and pushes the sodium in. These are the some of the causes for hypoosmolar hyponatremia due to reduced extracellular fluid. And what about hypoosmolar hyponatremia due to increased extracellular? Increased extracellular, for all intensive care trainees, it is very intuitive for you to know it is all the failure state, heart failure, liver failure, or renal failure, because there is no excretion of water, there is sort of anasarca, there is more of extracellular fluid. So you don't, and even here, the increase in sodium gain leads to more increase in the extracellular water. The etiology for hypoosmolar hyponatremia due to increased extracellular fluid is heart failure, cirrhosis of liver, where is a lot of extra third spacing, what we say, nephrotic syndrome, or oliguria due to acute kidney injury or chronic kidney injury. Even the pathophysiological reason for this is relative intravascular volume depletion and increase in the vasopressin. Please remember, for all hyponatremia, the etiology is increased vasopressin levels or antidiuretic hormone levels within the body. And hyponatremia due to normal extracellular fluid. So the most etiologies that come to ICU are because of this. They have normal extracellular fluid because the etiological factors are too many. And the commonest cause is SIADH. So SIADH is the commonest cause in ICU, which leads to hypoosmolar hyponatremia due to normal extracellular fluid. Where there is hypoosmolar hyponatremia, normovolemia, and urine osmolality will be always more than 100 milli, because there is increased ADH, which is storing more and more water within the body, and urine becomes more concentrated. That's why your osmolality is more than 100 milliosmol. And if you have to call SIADH, there are only two things you have to do. Please rule out adrenal insufficiency, and please rule out hypothyroidism. That's why we have to do cortisol levels, and we have to rule thyroid. And if thyroid is normal, cortisol is normal, normal extracellular fluid, hypoosmolar hyponatremia is almost always SIADH in ICU. Again, the pathophysiology is there is non-physiological increase in vasopressin levels, and the cause of SIADH in any chronic disease patient may have can lead to SIADH. Elderly people, somehow they tend to secrete more of vasopressin. They have more ADH as a defense mechanism, and neuropsychiatric manifestations, any malignancy, any chronic lung disease, any of the chronic diseases, elderly patients, or many a times etiology may not be known. The ADH levels will go up in elderly individuals, and SIADH is a very common cause of hyponatremia. Hypoosmolar hyponatremia with normal extracellular fluid, it's almost most often in ICU is due to SIADH once you have ruled out adrenal insufficiency and thyroid deficiency. And what about hyponatremia due to glucocorticoid deficiency and hypothyroidism? Again, it is hypoosmolar hyponatremia with normal extracellular fluid. Because as I said, increased extracellular fluid, writing is on the wall, and low extracellular due to fluid losses, and any endocrine deficiencies, it is with the normal extracellular fluid. And adrenal insufficiency leads to low cortisol. When there is a low cortisol, how does pituitary react? Pituitary reacts by producing corticotrophin releasing hormone. Whilst pituitary gets activated to produce increased corticotrophin releasing hormone, it also produces vasopressin. So for all hyponatremia, the pathophysiology is there is increase in the vasopressin production from the posterior pituitary. And along with this, when there is adrenal insufficiency, there can be hypoaldosteronism that also can contribute to, because aldosterone's role is to conserve sodium. Because it is not conserving, because hyponatremia happens. In hypothyroidism, how does hyponatremia happens? There is lower cardiac output. There is a lower GFR. And both of these leads to increased vasopressin levels, leading to hyponatremia. So when you are writing an answer on hyponatremia, or you have to recall the basic quintessential pathophysiology is increase in the antidiuretic hormone levels in the body and increased vasopressin production from the posterior pituitary. And what about pharmacological agents? There are a lot of pharmacological agents which potentiate and enhance the release of vasopressin from the posterior pituitary. All this can cause hyponatremia. Again, these are hypoosmolar hyponatremia due to normal extracellular. All drugs except diuretics cause hypoosmolar hyponatremia due to normal extracellular fluid. What are the drugs? Carbazepine and tricyclic antidepressants, anti-neoplastic drugs, antipsychotic drugs. All these leads to increase in the vasopressin release from the posterior pituitary, narcotics, nicotine. And there are drugs like which potentiate the action, which enhances the action of vasopressin, chlorpropamide, methylxanthines, NSAIDs. They potentiate, they accelerate the functioning of the vasopressin. And there are certain vasopressin analogs that we use in ICU like oxytocin or DDVP, which again retains the water within the body and causes hyponatremia. So these are the pharmacological agents, and there are other causes like stress, primary polydipsia, or acute hypoxemia and hypercapnia in ICU leads to increased ADH release, and they retain water and relative hyponatremia can set in. So these are all the causes of hypoosmolar hyponatremia due to normal extracellular fluid. The commonest cause in ICU is SIADH, and the second commoner ones, it can be due to cortisol deficiency or adrenal deficiency, or hypothyroidism is the more commoner endocrine cause. If those are not there, then the third category is all the drugs, which are all these. All the psychiatric drugs can lead to hyponatremia because they increase the vasopressin production from the posterior pituitary. So now coming to, so we have covered hypoosmolar hyponatremia due to reduced extracellular fluid, normal extracellular increase. Now we are talking about hyponatremia with normal osmolality. I said there are only two causes, hyperlipidemia and paraproteinemia. So why it happens? This we call it as pseudo hyponatremia, because when you look at the serum, so there is an aqueous portion and there is a sediment. So these are the sediments which are all proteins and lipids. And this is the water content which has sodium. So 93% of the plasma has sodium. The water content has sodium. The rest is the solutes, which are lipids and proteins. So if suppose look at this pictorially, if this solutes increase, if your proteins increase or lipids increase, your aqueous portion comes down. And that leads to relative, it reflects as a relative reduction of sodium. So if you see this is normal. Okay, so you see this is the aqueous portion. This is the water content which has sodium. And this is the lipid. You consider this as lipid and proteins. If lipids and proteins increase, your water content has come down. So your sodium is being reflected as low. That's why we call it as pseudo hyponatremia, because actually it is not low. It's the aqueous portion that is reduced because of increase in the sediments due to proteins and lipids, which is reflected as pseudo. So for all the trainees, hyponatremia due to normal osmolality, there are only two causes, which are paraproteinemias and hyperlipidemia. And I said for hyponatremia with hyperosmolality, there are only two causes, hyperglycemia and mannitol administration. Why that happens? Because if you have high sugars in the extracellular fluid, or if you have mannitol, there is high osmolality outside the cells, which will draw the water content from the body. So because there is a high osmolality here, the water content from the cells come out. Okay. So this happens in hyperglycemia and mannitol administration. And when this is there, this typically happens in DKE or hyperosmolar, hyperglycemic hyperosmolar state. For every 100 milligram increase in glucose, there is 1.4 millimoles drop in the sodium. That's why you would see in DKA, if sugars are 500 and sodium is 130, it means the sodium is always much higher, because 130 is a false reflection. Because for every 100 rise, you have to keep adding 1.4 millimoles sodium, and that is your true sodium. So that is our understanding. So I'm sure many of you would know that. The clinical manifestation of hyponatremia is they can have headache, confusion, coma, they can have seizures, they can have vomiting, they can have lethargy, malaise. So those are the non-specific sort of a clinical findings of hyponatremia. So diagnosis of hyponatremia, because the whole crux of understanding hyponatremia is to determine osmolality. Because as I said, most hyponatremia have low osmolality. That's why you have to determine whether if it is high osmolality or normal, the causes are very simple. If it is low osmolality, then you have to check urine osmolality, you have to check urine sodium and chloride. So when you are looking at diagnosis, again, you have to divide into three broad categories, whether it is normal osmolality, low osmolality, or hyper. If it is normal, you know there are only two causes. It's paraproteinemias or hyperlipidemia. If it is high osmolality, you know there are only two causes, hyperglycemia and mannitol administration. If it is hypoosmolar, then you have to determine what is the extracellular fluid, whether extracellular fluid is normal Increased or decreased? Increased, very simple, heart failure, liver failure, or nephrotic syndrome. Decreased, then you know it is diuretics, vomiting, diarrhea, increased sweating. If it is normal, I said most causes come under SIADH or drug-induced or endocrine causes, which is hypothyroidism or hypoadrenalism. So hypoadrenalism, hypothyroidism, increased heart failure, cirrhosis, nephrotic, decreased, it's all vomiting, diarrhea, and diuretics. And if plasma osmolar is hypoosmolar and reduced extracellular fluid, then you have to do urine sodium. If urine sodium is less than 10 millimoles, then you know there is a lot of sodium losses due to vomiting and diuretics. If it is more than, or diarrhea, if it is more than 20, then it means that there is hypoaldosteronism or there is a lot of renal losses of sodium. So that is the algorithmic approach of hyponatremia. And you have to do urine osmolarity. If it is less than 100 milliosmol, then if specific gravity is low, because urine is very dilute, then possibly the reason is primary polydipsia, where patient is drinking a lot of water. If it is more than 100 milliosmoles, then you know there is increase in the ADH levels, and that is concentrating the urine. So that is the sort of a brief algorithmic approach in establishing the underlying diagnosis for hyponatremia. So the treatment, there are three goals, almost always hyponatremia due to hypoosmolar hyponatremia. The treatment is water restriction because there is a lot of water in the body because your ADH levels are high. It is not allowing the water to be excreted by the kidney. You have to do water restriction. Please don't give saline or any fluids when someone comes with hyponatremia. And you have to create or you have to facilitate water loss and restrict the water ingestion, and you have to replace sodium with 3% saline or hypertonic saline and correct the underlying cause. When you are replacing the sodium by hypertonic saline, you have to do the desired correction rate. Correction rate is desired change. What is the rate of change that you are desiring? And multiplied by free water. Free water is 0.6 into body weight for males, 0.4 into body weight for females. And desired change should not be more than 8 millimoles per liter per 24 hours. So that is what you need to. So it should not be more than. So the simplistic way is you do 8 into, if it is a 80 kgs. So if it is 0.5 into 80, it will be 40. So 40 into 8, 4 8 is 32, 3.2 liters. So it should be, the calculation should happen in that way. Your correction rate should not be more than 8 millimoles per liter per 24 hours. And that is the formula. Desired change you see and into free water calculation. So, and there are certain specific causes where the sodium is low and potassium is high. And this we see, there are only few causes. So whether patient is taking aldactone or spironolactone, which will cause low sodium and a high potassium, or you have addisons, adrenal deficiency, adrenal insufficiency, or in DKA. These are the only three causes where sodium is low and potassium is high. That's why if you see hyperkalemia with low potassium, always do a cortisol level and look at whether they have addisons or they can have hypoaldosteronism, because hypoaldosteronism, there is failure to retain sodium and potassium tends to go up, and salt losing. So that's about hyponatremia. It's a little broad topic. Keep listening to this. It's a very simple. Unless you know the concepts, you won't have a clarity on how to approach hyponatremia. So going further with this case, 65-year-old man, you corrected sodium. Then the repeat sodium after few days, you see sodium is 168. So he's developed hypernatremia. So question is, how would you treat this hypernatremia? If it is hemodynamically unstable, you can use saline as resuscitation. But if hemodynamically stable, then the whole problem with hypernatremia is there are only two causes. Either it's water deficit or more sodium. So you have to correct free water. Either you correct free water with half saline or 5% dextrose, and you can use adjunctive enteral free water also to correct free water. And free water deficit, how do you calculate? You have to have total body water, which is 0.6 into body weight, and look at measured serum sodium. If it is 168, you minus by desired serum sodium, which is 140 divided by 140. And that will give you the number of liters of free water that you need to correct. And the rate of infusion in acute should be 1 millimoles per liter per hour. In chronic, you can use at 0.5 millimoles per liter per hour. So this is the rate of correction for hypernatremia. In hyponatremia, it should not be more than 8 millimoles per liter per 24 hours. Okay, so that is what you need to bear in mind. So now coming to a case study 2, which is a 55-year-old woman with cellulitis. She has sepsis or infection. But look at her comorbidities, diabetes, rheumatoid arthritis, and she was taking steroids, metformin, methotrexate, and prednisolone, and she has stopped prednisolone because there is infection. So what is the obvious diagnosis? So this patient is come with tachycardia and hypotension. So patient with rheumatoid arthritis, been taking steroids, she has stopped because there is infection. She's come with hypotension. You can call it septic shock, but one thing that is striking you is because she was steroid dependent, there is secondary additions. There is relative cortisol deficiency in this patient. So how would you treat? So in this, she may have sepsis. Obviously, you will treat antibiotics, treat the underlying cause, but there may be relative cortisol deficiency because she was on steroids. Obviously, you have to give fluids, vasopressors. Most important in this patient is you have to replenish. That's why history taking becomes important. Someone who has been on steroids, if they come with hypotension, please bear in mind they may have relative cortisol deficiency. You have to give hydrocortisone 200 mg once a day. And obviously, you have to establish the diagnosis. Send the cortisol before you give hydrocortisone so that if there is hypocortisolismia, that can be detected, or give a ACTH stimulation and see if cortisol level rises to adequate levels. And then treat the underlying cause with cellulitis. If they need debridement, surgical debridement, antibiotics, so on and so forth. But almost always remember, someone who's on a chronic steroid use, when they come with hypotension, the first thing is you have to resuscitate with fluids, vasopressors, and give steroids after checking random cortisol or checking the syntrophin ACTH stimulation test. Okay. So that's about, so we finished hypokalemia, we finished hyperkalemia, hyponatremia, hypernatremia. Then very quickly, we'll talk about hyperglycemic syndromes. So this is a 22-year-old patient, type 1 diabetes, come with pH of 7.16, glucose 240, bicarbonate 12, anion gap 20, and ketone bodies is positive. So what does this mean? So obviously, this patient is acidotic with a severe high anion gap with a ketone bodies positive. So this is a DKA, isn't it? I mean, it is, writing is on the wall. Then you have a 58-year-old patient, no chronic illness, comes with bicarb of 30. Look at the sugar, very high, 1640, and ketone bodies is 1 plus. So very likely the first one is DKA, second one is hyperglycemic hyperosmolar state. So one needs to appreciate the differences between DKA and hyperosmolar. DKA sugars will not be very high. It can be 250 to 600, but in hyperglycemic hyperosmolar state, it will be very, very high, 600 to 1000. pH will be very acidotic in DKA, but HHS, it will be around 7.3. Anion gap is high, almost always high in DKA. In HHS, it can be normal to slightly high. Osmolality will be much higher, because that's why it's called hyperglycemic hyperosmolar state. And urine ketones are very positive. It will be 3 plus in DKA. In HHS, it will be either plus, it may be present or may not be present. So these are some of the key differences between DKA and HHS. And initial evaluation of DKA, you have to assess the mental status, degree of hydration, and you have to treat the underlying infections. Obviously, you will check for glucose, ketone bodies, arterial blood gas, ECG, echo, because it's a hyperosmolar state, they are at a risk of stroke and MIs. So the management of DKA and hyperosmolar is always fluids. Crystalloids is the mainstay. And then you have to start insulin infusion at 0.1 to 0.15 units per kg and get the sugars down. So the key aspects of resuscitating DKA is almost always fluids. There will be deficit in fluids up to 10 to 12 liters. So the three main things is give fluids, give insulin, and when you are giving insulin, potassium comes down, you have to replenish the electrolytes. The third component is replace potassium and maintain potassium between 3.5 to 5. And if potassium comes down to less than 3.3 in the context of giving increased insulin, you may have to hold insulin for some time. Correct potassium. When you are correcting potassium, please bear in mind in DKA, you have to correct even magnesium and you have to correct phosphorus also. Even phosphorus also comes down. All these have to be checked every 4th hourly and corrected. And continuous insulin infusion has to be given, and please try to avoid hypoglycemia. If sugars come less than 250, you have to change over from normal saline to DNS or dextrose with insulin to prevent hypoglycemia and maintain sugars at 140 to 180. And having a protocolized management in DK or HHS helps in saving lives. So that's about it, friends. So it's a very broad topic. So try to give you a brief overview on the principles of causes of hypokalemia, management of hypokalemia, causes of hyperkalemia, management of hyperkalemia, Hyponatremia is a broad topic. We looked into detail the causes and the approach to management of hyponatremia, hypernatremia, and hyperglycemia, which is either DKA or hyperosmolar state. So thank you, one and all.